Thank you. Good evening, everyone. Welcome to another session of Young Family Physicians Forum. Today, our speaker is Dr. Janani Fernando, Registrar in Family Medicine from 2023 year batch. To give an introduction to her, I invite Dr. Gayani Minuapitia, Registrar from the same batch. Over to you, Gayani.
Thank you. Dr. Janani Fernando graduated from the Faculty of Medicine, University of California, and obtained her diploma in family medicine in 2022. Currently, she is a second year registrar in family medicine. Janani, over to you.
Thank you for the kind introduction, Gayani, and good evening, madam and my dear colleagues. My presentation topic is fever and joint pain in children. The reason to choose this topic was as we have frequently came across children with joint pain and fever, mostly came across in the internal wards, and I thought of doing a presentation on this topic as it is an interesting and most of the cases they have been referred and recognized initially from the primary care physicians, and knowing about fever and joint pain in children is worth. So for that I have For that, I have selected 5 different cases which we came across in the same unit, pediatric ward Nigambo. And to initiate with the case 1, there was a 4-year-old boy, previously well child, presented with fever for 4 days and bilateral foot swelling for 2 days duration. He has had cough and cold 1 week back, which was self-limiting, settled within 3 days, and after 2 days of illness-free period, he has developed fever and taken treatment from OPD. Day 2 of the second episode of this fever, he has developed bilateral swelling of dorsum of feet, and there was pain and tenderness, and lymph was there. Even though there was lymph, range of movements were preserved. No axial or other large joint or small joint involvement was there. No GI or GU symptoms, no rashes, no history of trauma, no eye symptoms, or appetite was normal. Respiratory symptoms not significant, no chest pain, and he has not had previous similar episodes, and family history was unremarkable. On examination, he was febrile, and there were lymphadenopathy in left cervical and left inguinal, which was spotty. Bilateral epitrochlear also was there. Bilateral feet, mild swelling without inflammation was there. Within 24 hours, the swelling was settled spontaneously, gait became normal, and fever settled. And these are the summary of the investigations to see. And inflammatory markers were high, more than 100. ASOT was high, 400. And other investigations were unremarkable other than the ultrasound abdomen, which showed mesenteric adenitis. So from this short history, this is the summary. 4-year-old child presented with fever, with bilateral foot swelling, with recent mild viral illness. Even though lymph was there, range of movement preserved, with high inflammatory markers and ASOT. Within 24 hours, it resolved spontaneously. So do you have any thoughts, any differential diagnosis you can think of? Hello. These were the most probable diagnoses they have taken at the initial stage. And with the presentation move on, we'll see what is the exact diagnosis is. And this is the case 2. 10-year-old boy presented with fever for 4 days and left foot pain and swelling for 1 day. He has been well previously, has had cough and fever for 5 days, and day 4 of the illness developed left foot pain and swelling. On the same day evening, with left foot swelling, developed right foot swelling as well, then moved to left hand small joints and right shoulder joint. This was not flipping and feeding type joint involvement in the next day. Day 5 of the illness, after admission, left knee joint pain and swelling also developed. All the other systems were unremarkable, and there were no similar episodes as well. On examination, all the above-mentioned joints, visible swelling was there with mild tenderness, but range of movement preserved. No sign of inflammation, no axial involvement. Only positive findings were he had bilateral cervical lymphadenopathy and vitals normal. When we move on to the investigations, as the previous case, inflammatory markers were high, but here ASOT was negative. That's the only difference from case 1 and 2. This is the summary. 10-year-old boy presented with fever and foot swelling. Foot swelling, which was non-migratory, it is additive pattern, and inflammatory markers high with normal ASOT. These were the DDs they have taken when considering this child. They are reactive arthritis, rheumatic fever, and undifferentiated polyarthritis. This is case 3. 13-year-old boy presented with left lower limb edema for 2 days. He has developed sudden onset myalgia with left lower limb pain, more in ankle joint. Initially, he had no fever, and the right limb was normal. On day 2 of the illness, he has developed a rash which was mildly itchy, palpable, spread over bilateral lower limbs. And prior to this illness, he had a 1-day history of 1 episode of vomiting and 4 days of diarrhea prior to this illness. And day 3 of the illness, initially he started from left lower limb. Then day 3 of the illness, bilateral elbow joint pain and left hip joint pain developed, but no significant swelling, even though the range of movement reduced. During this period, the rash spread to bilateral hands. On day 4, he developed redness of the right eye, spread bilateral eyes then. No small joint involvement, no axial involvement, and other systems were normal. On examination, the rash was palpable, discrete, hyperpigmented, with overlying crust, initially spread from bilateral lower limb up to knee, involving dorsum of the feet, and bilateral upper limb from below elbow to hands, involving both palms and dorsum. Joint swelling with inflammatory features were there at left ankle joint initially, but spontaneously subsided. When we were examining, there were no significant elbow joint or other joint involvement were not seen. Bilateral sclera reddish, vitals normal. When we looked into the investigations, the inflammatory markers were not that high, and in UFR, red blood cells were present, 50 to 60, and all the bleeding clotting profile was normal, ASOT negative, and they have done a couple of investigations other than the previous case, as he had significant myalgia with the history, and his clinical picture is uncongruent. That's why. So the CPK levels were 900, more than 900, rheumatoid factor positive, and ANA was positive. This is the summary. 13-year-old boy presented with left lower limb edema, palpable rash, red eye, and with left lower limb edema, there were elbow and wrist joint pain and swelling as well, and high CPK levels, rheumatoid factor positive, and ANA positive. These are the DDs they have taken when considering this child. It was HSP, Hennection line purpura, or SLE, or JIA. And this is case 4. 11-year-old girl with bilateral knee joint pain for 1 week. She has presented with bilateral knee joint pain. It was progressive over 1 week. Interestingly, she has had no fever. Pain persists while rest and movements. Reduced range of movements and limping was there. She was unable to weight bear also. There's no history of trauma or other system involvement. No axial or small joint involvement was there. The only positive history she had was respiratory infection, which had 2 weeks prior to this episode. On examination, bilateral knee joint, no swelling or tenderness. Pain on movements were there, but bilateral hip joint range of movement, even though the range of movement was there, pain on passive flexion noted. And they have done x-rays on hip joint and knee joint as well. All the blood investigations normal. The above mentioned x-rays were also normal. This is a summary. 4-year-old girl, bilateral knee pain for 1 week, pain on movement, limping, no swelling, no fever, with post-respiratory infection. This is the probable diagnosis we have taken in the ward to treat her. This is case 5. 13-year-old girl with fever for 1 week, bilateral elbow joint and wrist joint pain for 2 days. She has had on and off fever for 1 week. On day 8 of the illness, developed bilateral elbow joint pain, and next day, the severity of the elbow joint pain reduced, and simultaneously, the pain developed in wrist joint with reduced range of movements. Typical treating and fleeting type pain. No axial involvement. All the other systems were normal other than the mild coryzal symptoms. On examination, mild wrist joint swelling and tenderness was noted. When we were examining, elbow joint swelling has already settled. All the other system examination was normal and vitals normal. Cardiac, no, there were no murmurs. Here to see, similar to some of the previous cases, inflammatory markers were high, and echo was normal, ECG normal, PR normal, PR interval, and ASOT was slightly high. Here also the most probable diagnosis we considered were reactive arthritis and rheumatic fever. And as she had flitting and fleeting type migratory pattern, treated as rheumatic fever. This is the summary. And to see that above mentioned 5 cases, is the presentation same? Some of them were same. And are the examination findings different? Is the progression different? Can they all fall into same category? Is the initial diagnosis the exact diagnosis? And do they need follow-up, and why? Can they manage in primary care? So when to get the opinion from secondary or tertiary care? So to answer above, need more detail. Now, let's move on to the cases were not interesting initially, but in the end, there were some interesting diagnoses. So let's find out. Joint pains in children, which is common and affect 10 to 20% of school children. So correct diagnosis is a must. So, all joint pains are not arthritis, as well as all arthritis are not present as painful joint. Any child with musculoskeletal pain, sorry, we have to definitely differentiate the problem, whether this is in the joint or whether this problem is related to the joint, as some may have pain or referred pain, which mimic joint pain, but the pathology is elsewhere, like Perthes or Souffle. Arthritis is per se is a diagnostic challenge, and this is the definition. To diagnose arthritis, there should be either swollen joint or at least 2 of the following: reduced range of movements, pain on movement, warmth overlying the joint. From here, we can see that to define arthritis, to say that this patient is having arthritis, there should not necessarily, should not be a swollen joint should be there, because if you have either these symptoms, you can put them into this category of arthritis. If a child presents with joint pain, the child there can be single joint involvement with or without fever, or else multiple joint involvement with or without fever. The major differentiation factors are whether this presentation is acute or chronic, and number of joint involvement, and the presence of fever. These are some examples. If a child presents with single joint involvement with fever, some of them are emergencies, and some of them are very common presentations, and some diagnosis we should not miss. We have to keep in back of our heads that whether this is this presentation showing a red flag. The examples are septic arthritis, reactive arthritis, osteomyelitis, JIA, bone tumor, sarcoidosis, traumatic arthritis, or TB. These are some examples. If a patient presents with single joint involvement without fever, trauma, hemarthrosis, avascular necrosis, hemoglobinopathies, and either this could be a psychogenic pain. If a child presents with multiple joint involvement, the history of fever, again, some of the examples which belong to this single joint involvement is also coming in this category. Reactive arthritis, rheumatic fever, systemic onset JIA, poly-JIA, vasculitis, IBD, inflammatory bowel disease, sarcoidosis as such. Multiple joint involvement without fever, JIA, dermatomyositis, post-immunization, fibromyalgia, malignancy, and lastly, chronic fatigue syndrome. So to differentiate, as I mentioned earlier, number of joint involvement, presence of fever, and presentation pattern and the duration. This is the progression of the disease. And extra articular manifestations, we have to find out which way to this patient's history moving. Comprehensive history taking and detailed examination is very important, and lab investigations can facilitate the diagnosis. To answer the previous slide, we can divide our history into these categories: demography, disease chronology, inflammatory nature, progression, distribution of joint involvement, extra-articular manifestations, precipitating factors, family history, and red flags. Because when we consider age, certain age groups, certain diseases are more commoner than other age groups. These are some examples for that. In early childhood, Kawasaki disease, HSP, rheumatoid factor negative polyarticular JIA is more commoner. In late childhood, enthesitis-related arthritis, SLE, and rheumatoid factor positive polyarticular JIA is common. When we consider about the onset of the disease and duration, acute onset illnesses which present with joint pain and fever are septic arthritis, Kawasaki, HSP, self-limiting viral arthritis, rheumatic fever, and reactive arthritis. Acute onset means less than 6 weeks, and subacute or chronic, the examples are polyarticular JIA or sarcoidosis. Characteristic of the pain and association with stiffness will narrow down our diagnosis, as morning stiffness more towards inflammatory arthritis, and nocturnal pain, we have to suspect malignancies as well. The extra-articular features, each and every system can get involved in a child with different types of arthritis. In gastrointestinal, they can present with diarrhea. They can, then urinary system, they can present with features of UTI, hematuria, or proteinuria, or adolescent urethral discharge. Eyes, pain, swelling, or redness. Central nervous system, headache or convulsions. Skin can present with rash or mouth ulcers. Cardiovascular system, palpitation, chest pain, SOB as such. We can ask precipitating factors which we can identify to this illness. with like trauma, infection, immunization, or exposure to TB. These are the red flags, some of the red flags we should not miss: fever, malaise, loss of appetite or loss of weight, and bone or joint pain with fever itself is a red flag. And that's why I thought of doing this presentation other than the frequent presentation in the ward. This is a red flag. Persistent night pain, incongruence between history and the presentation is also a red flag. There can be a family history of bleeding disorders, so HLA 27 associated diseases like inflammatory bowel disease, psoriasis, ankylosing spondylitis. That's all for the history. And when we move on to the examination, we have to find answers to these categories, whether this is articular or non-articular, the pattern of the joint involvement, whether this is inflammatory or non-inflammatory, the pattern of fever, and general examination, basically extra-articular manifestations. To categorize if a patient comes with a limp or pain and fever, pain of a joint and fever, there's a screening tool they have been introduced, which called PGALS. It's not a scoring system. This is a screening tool that we can memorize it and help us not to forget what we should look into. P for pediatric, then gait, arms, legs, and spine. We have to ask 3 questions to check functional limitations. We can ask pain and stiffness in the joint, muscles, or back, whether they're having a difficulty in dressing, difficulty in going up and down stairs. To check the gait, observe walking, walk on tiptoes and heels with all the children, and arms, ask to make them a fist, touching fingertips with the thumb or squeezing metacarpal joints will show us whether there are any articular inflammatory involvement is there. And when we look into legs, knee joint range of movements, passive flexion and extension of hip joint, and also we have to check for effusion in the knee joint as well. And S for spine, range of movement of spine, and observe for any deformities. And to find the number of joint involvement in the examination and the history is important, so that certain diseases they present with they can differentiate from whether this is monoarthritis or polyarthritis, acute or chronic. So acute monoarthritis, some examples are infective, reactive, JIA, malignancy, trauma, mechanical. Acute polyarthritis can be post-viral, rheumatic fever. Chronic monoarthritis can be TB or malignancy also. And chronic polyarthritis can be JIA, mechanical, metabolic, or vasculitis. Axial or peripheral involvement, we have to check axial involvement in spine, sacroiliac joint, sternoclavicular joint or mediasternal joint involvement, and root joints such as shoulder joint and hip joint. Peripheral is all the extremities. Pattern of the involvement. Additive. that they start from one joint involvement, and without settling, it move to another joint involvement, which is additive. Example is polyarticular JIA. Migratory means flitting and pleating. That is, they start with one joint, and once the problem in that joint settled, then the pain and swelling move to the other joint. This is the example is rheumatic fever, and the joint involvement is intermittent. Sometimes in some periods they are totally okay, and sometimes they have joint involvement. Examples are SLE, sickle cell, or hemophilia. We can consider symmetrical, whether this is symmetric or asymmetry. Symmetrical involvement more towards inflammatory connective tissue disorders, SLE, polyarticular JIA. Asymmetric involvement can be present in oligoarthritis JIA, psoriasis, reactive or septic arthritis. Deforming or non-deforming. Deformity can be present in long-standing or aggressive disease with like an example like rheumatoid factor positive polyarticular JIA. Even though there are chronic disease, but non-deforming pathologies are SLE, inflammatory bowel disease, malignancy, or reactive arthritis. When we consider the presence of fevers, certain diseases, the fever pattern is different, and we can get a clue from the fever chart as well. Septic arthritis Kawasaki is very ill child, high fever, and Soja systemic onset JIA daily fever, not that ill, and like lymphoma, Pell-Epstein fever, that they can have couple of weeks fever-free period and then again develop fever. That's Pell-Epstein fever. And once we have done the articular examination of the articular involvement, then we have to move on to the general examination. Rashes, pattern and the character, eye involvement, mouth ulcers, nail pitting, hepatosplenomegaly or lymphadenopathy. Eye, physical eye, when we consider eye, anterior posterior uveitis in JIA, non-exudative conjunctivitis in Kawasaki, reactive arthritis, and keratoconjunctivitis in sarcoidosis. Oral cavity, oral ulcers in SLE, strawberry tongue or cracked lips in Kawasaki, maladiscoid rash in SLE, rotten papules in juvenile dermatomyositis, palpable purpura in HSP, erythema nodosum in PAN or sarcoidosis, genital ulcers in reactive arthritis. Nails and hair involvement, alopecia in SLE, nail pitting, onycholysis in psoriasis, and clubbing in inflammatory bowel disease. Musculoskeletal system, proximal muscle weakness, muscle tenderness in juvenile dermatomyositis, and muscle tenderness in JIA as well. Enthesitis related arthritis can be present. Vascular system, gangrene stroke can present, SLE can present with gangrene or stroke, and lymphadenopathy can present in SLE, Kawasaki, JIA or malignancy. Renal involvement can be seen in JIA, SLE, PAN, Kawasaki or HSP. Stroke, seizures, psychosis or chorea in rheumatic fever, SLE, polyarthritis nodosa. And lung involvement can be seen in with hilar lymphadenopathy and infiltrates in sarcoidosis and pan. Investigations, it contributes up to a certain extent in final diagnosis with minimal role in arriving a probable diagnosis, as no lab test can confirm the diagnosis, and absence of disease marker doesn't exclude the disease unless it supports the conclusion, such as evidence of inflammation or infection. So I am going to discuss in detail about the diagnoses we have come across in my 5 cases above. First one is reactive arthritis, which is common, usually lasting up to less than 6 weeks, commonly involve lower body, knee joint, ankle joint, or foot. It is a sterile inflammatory arthritis, can come with extra-articular infection, commonly GI or gastrointestinal or genitourinary. The common triggers are GI infection, Salmonella, Shigella, Campylobacter yersinia, GU infection, Chlamydia, Trachomatis, gonorrhea. Less commonly viral, Mycoplasma, tick fever, or post-streptococcal reactive arthritis. If you can remember the first case, a child with history of fever and foot pain which settled within 24 hours. She has had high inflammatory markers and ASOT around 400. And our differential diagnosis were whether this is reactive arthritis or rheumatic fever. And as the swelling settled within 24 hours and all the other symptoms subsided, they have taken her as post-streptococcal reactive arthritis, which is less common. The clinical features of reactive arthritis: asymmetrical, oligoarticular, commonly lower limbs. They can also present with conjunctivitis or uveitis, urethritis, cervicitis, enthesitis, especially Achilles tendon involvement, and cutaneous lesions as oral ulcers. Diagnosis is clinical based on history and presentation with supporting investigations of high inflammatory markers. In any case, we have to exclude septic arthritis because it is a pediatric emergency. So it's interesting to have a few slides on septic arthritis as well, because when we see a child with fever and arthritis, joint involvement, when we, as our method, hypothetical deductive method, the most probable diagnosis is first, then we have to rule out some common red flags, common emergencies belongs to that age group, and septic arthritis is in the top of that list. Definition of septic arthritis is acute infection of joint space by bacteria leading to inflammation and joint destruction. It is serious as this infection in the joint space can destruct the bone, so urgent treatment is a necessity. Most commonly, the most common age group is less than 2 years. Usually the spread is hematogenic and can spread adjacent osteomyelitis where the capsule insert below the epiphyseal growth plate. Common pathogens are in children, Staph aureus, Haemophilus influenza, Streptococcus species, adults, Staph aureus, Streptococcus, Neisseria gonorrhoeae is also a common possibility, and immunocompromised patients, gram-negative organisms can also cause septic arthritis. Risk factors for getting septic arthritis are pre-existing joint disease, immunosuppression, recent joint surgery or injection, trauma, or IV drug use. Clinical features: septic arthritis is acute monoarthritis with severe joint pain, swelling, redness. The child is unwell, with high fever. In infants, pseudoparesis or paralysis can be there, and crying on movement will be the presentation, and decreased range of movements, joint effusion. The source can be a puncture wound or infected skin leak, overlying skin infection. The diagnosis arrives with the joint aspiration with purulent fluid or presence of pus cells and gram stain and culture. We have to do blood culture and imaging to assess the effusion osteomyelitis. X-rays will be done to detect trauma or other lesions, and MRI to detect adjacent osteomyelitis. Management is urgent IV antibiotics empirically, then joint drainage, either needle aspiration, arthroscopy or open surgery, and immobilization during the acute phase, followed by physiotherapy. This is another interesting diagnosis we came across in my first mentioned one of the child with rash and polyarthritis features, juvenile idiopathic arthritis. In definition, a group of autoimmune inflammatory joint disorders occurring in children less than 16 years, lasting more than 6 weeks with unknown cause. Commonest chronic inflammatory arthritis in children, and 95% clinically and immunologically is distinct from rheumatoid arthritis in adults. Classification according to the International Arthritis Association, categorized as oligoarticular, less than 4 joints, polyarticular, more than 5 joints, systemic JIA involving fever and rash, enthesitis-related arthritis, polyarthritis, psoriatic arthritis, and undifferentiated arthritis. And the 7 subtypes based on number of joint involvement in first 6 months of the illness. I have put a small summary here to call it oligo. Oligo can be divided to oligopersistent, which means joint involvement includes 4 joints maximum. And oligo-extended means more than 4 joints after first 6 months. And with each subtype, the more common age group is different. Oligoarthritis more common in small age group, and oligopersistent in ankle joint, knee joint, wrist joint. Oligo-extended, asymmetrically large or small joint involvement can be there. And poly-JIA means in the first 6 months, more than 4 joints. And it can again divide it with the positive or negativity of the rheumatoid factor. Rheumatoid factor negative poly-JIA is more common in children, 1 to 6 years. And rheumatoid factor positive JIA is in adolescents, which has poor prognosis. And systemic JIA also has a poor prognosis with fever, rash, lymphadenopathy, hepatosplenomegaly, and serositis. And there's 7% of subgroup which belongs to the psoriatic JIA with involvement of nail pitting, destruction, and chronic anterior uveitis. The age runs from 1 year to 16 years. Enthesitis related means HLA-B27 positive, commonly involved Achilles tendons, Achilles tendon, and the age group is 6 to 16 years. Clinical features of JIA, similar to others, joint swelling, stiffness. Main differentiating factor is that morning stiffness is there as rheumatoid arthritis in adults, and limping or refusal to use limb, growth disturbance in chronic cases, systemic symptoms, and eye involvement. Diagnosis should arrive with clinically and after excluding the other causes. Lab investigations, high inflammatory markers, and ANA can be positive and rheumatoid factor can be positive. X-rays or MRI can be done to assess the damage, joint damage, and regular eye screening should be done. Management-wise, NSAIDs, DMARDs, biologics, plus physiotherapy and occupational therapy get involved, and eye monitoring for uveitis as well. And this is the other diagnosis, the fifth case I have mentioned before, rheumatic fever. The definition is an autoimmune inflammatory disease that follows group A streptococcal pharyngitis affecting the heart, joints, skin, or central nervous system. It caused by an abnormal immune response to Streptococcus pyogenes, typically occur 2 to 3 weeks after untreated or partially treated strep throat. This is the from devised Jones criteria. We can diagnose rheumatic fever. Evidence of group A streptococcus infection should be there. That means ASOT or PCR should be positive, plus 2 major criteria or 1 major plus 2 minor criteria. The features belongs to the major criteria are migratory polyarthritis, carditis, Sydenham chorea, erythema marginatum, and subcutaneous nodules. Minor criteria is fever, arthralgia, increased inflammatory markers, prolonged PR interval on ECG. Clinical features: fever, sore throat history, polyarthritis, which is migratory, new murmurs or signs of heart failure can be present, involuntary movements for chorea, and skin findings, rash or nodules. Management is antibiotics, penicillin, anti-inflammatory with aspirin or NSAIDs, corticosteroids for severe carditis, and long-term prophylaxis with penicillin. from this presentation, and this we are coming to the end of the presentation, and I have to say what not to miss. Arthritis. So arthritis-like symptoms can be presentation of a leukemia or TB, like serious illness, and many rheumatological diseases have extra-articular manifestations. Identification of joint emergencies is a must for the management, as examples as septic arthritis, rheumatic fever, or soja. It may be not possible to come to a conclusion at first visit, and as several rheumatological diseases evolve with time. Because we have informed that there was one case initially presented with reactive arthritis. Then during the next visit, with the investigations and the evolvement of the joint disease, the child has been diagnosed as JIA and has been treated with steroids and other drugs. And in the ultimate diagnosis was ALL. So that's why we cannot, if we diagnose a child with a uh, certain type of arthritis, we cannot let him go. That we have to get him down again and see and examine, and the involvement of the investigations, we have to see whether this is truly
Oh, mommy.
disease. Yes, madam. And so the pattern recognition is important. So throughout this presentation, I was trying to show some patterns that we can narrow down our diagnosis and come to a most probable couple of diagnoses which can be investigated, and with the involvement repeated visits we can find out. The other things, that there was a case which I have mentioned in this 5 histories, were transient synovitis, which I have not mentioned here. And it is also followed by a viral infection, and child can be present with sudden onset pain or limp, and this pain can be referred to knee, and the original problem is in the hip joint, and it is also a most common cause of acute hip pain or limp, and with bed rest, and it's self-limiting and no other blood investigations normal. In summary, pediatric joint pain encompasses a wide differential, including transient infection, inflammatory, traumatic, and malignancies. Transient synovitis is the most frequent benign cause in young children, self-limiting but important, differentiate from other serious problems, serious arthritis. Septic arthritis is a medical emergency. Early recognition and intervention is important. JIA is the most prevalent chronic rheumatoid condition in children, which have subtypes and variable presentation. Systemic illnesses like SLE, leukemia may present initially with simple musculoskeletal problem, where the importance of holistic diagnostic approach is important, appreciate, and evaluation must include a comprehensive history, detailed musculoskeletal examination, and supporting lab investigations and imaging. Multidisciplinary care because is needed at one point, involving pediatrics, rheumatology, orthopedics, and physiotherapy, which is key to optimal patient outcomes. And these are my references. And thank you for listening. That's the conclusion of my presentation.
Thank you, Dr. Janani. So I invite the audience to bring forward any questions that you have for the speaker. So just I have one question myself. So I want to clarify.
Yeah.
So you said in monoarthritis, even reactive arthritis per se can have a monoarthritis with fever, and then
Yeah.
again septic arthritis also may have monoarthritis and fever. So
Yeah.
how would you could you elaborate how you would differentiate it in the first presentation clinically? Or
Clinically,
the have to, yeah.
when we are considering the well-being of the child, the septic arthritis child is more ill and really unwell with high fever. The involved joint um, is very painful and it's not moving. We can very tender redness, swollen joint will be there, and all the inflammatory markers will be sky high. And when comparing the clinical presentation, the reactive arthritis children, even though there is pain and swelling, they can actually move. I mean, comparatively, that septic arthritis joint is very still joint. They cannot move it, and the patient is very ill, and that's give us a clue to find out whether this is actually septic arthritis is also not. And also, if on examination we can, the effusion can be find, can we can get effusion, and then with tap or uh, surgery we have to investigate for septic arthritis. That's what I thought of.
Yeah,
All
very
right, thank you.
correctly mentioned. Like for first of all, anyhow, whatever said and done, now it's done. It's a very nice presentation. I know it's a huge, a huge uh, section. It's not no one like sort of cover in few minutes or just a 1 hour, but it's a huge thing. But you try to do it in a very precise manner. Anyway, according to the question, the question is how to differentiate septic from reactive. So I would like to ask the question again from you. What is reactive and what is septic? What's the difference? What do you mean by septic and what do you mean by reactive? But I think the seniors, more seniors also there. What is reactive and what is septic? So the answer is they are inside, not like you don't have to think too much. Infection, receptic means what? There's an infection, ongoing infection is there. Nicely describe that, no? So what is then the reactive? So it's a sort of a autoimmune response to some kind of infection. There is no active infection there, but it's a sort of autoimmune response. So that response is not so severe than the current infection. So that's the difference. So that's why the patient is very toxic in septic, not so toxic in reactive. Got the point?
Yes, madam.
Yes, ma'am.
Thank
So
you.
that should be the way, right? Anyway, so when you consider all the presentation, What did you gather from, like, in a nutshell, one or two? Just tell me one. I mean, few people. I mean, there are about 33 people. Could you please tell one or two things you gathered from this presentation? The first thing, of course, as she mentioned, you cannot miss septic arthritis. That's the most important. Why? Why you cannot miss septic arthritis? I'm talking about the
So,
children, right? Yeah.
it can lead to mortality and morbidity because of
We'll
sepsis.
say the
As well as
complications. What are the complications? If you like, I mean, don't treat the person at the correct time.
there will be persistent joint damage, madam, with the septic arthritis is
And
treated.
according to the description, like that is the like she mentioned correctly. And because of the joint destruction, what will happen? That's what my question.
Joint deformities will be there for life.
Yes, deformities. What else? Where is the problem now? In the joint means what is the main, like deformities, of course, even in the adults. What is specifically what we have to, secondary osteoarthritis, the one, okay, fine. That also again for this in the chat box there's answer. Because it again leads to some sort of deformities. More than that, related to growth, what will happen? Because where is the problem? Joint destruction. Where is the destruction?
Growth plates.
Yeah, the growth involved into the growth plates. So that's because then there will be some kind of like, if it is mono, then it's again a problem. The patient is maybe the handicapped person forever, like, because of that you cannot miss. Other than that, anything, something like that, we'll say maybe some kind of there, because other thing is though the patient is having some kind of a musculoskeletal means some arthritis, they don't come with joint swelling. So that is the most important thing. Maybe just the pain or maybe limitation of movements with extraarticular manifestations, right? So if there are a lot of extraarticular manifestations with some joint pain, what you have to, you cannot miss. What you cannot miss in that way. Give joint pain and lot of extraarticular manifestations, what you cannot miss. Anybody? There are about 30 odd people. What you cannot miss. SLE. Remember that. You cannot miss SLE. So those are the things you have to remember. Because of that, I think it's a huge section, right? She was trying to cover. But anyway, you have to like go through all the slides, and if you need any, you can refer some books. But anyway, it's very good, like the way she presented and everything. Okay, then. Thank you very much. And do you want to talk about Janin? About
Thank you very much, madam, for the guidance, and thank you, Dr. Neri, presentation. I think with that, we can wrap up today's session and hope to meet you all again in about 2 weeks' time. Thank you and good night.
Thank you very much, madam.
Thank you, madam.